Dr. Chatzkel received his MD degree from Perelman School of Medicine at the University of Pennsylvania, Philadelphia. He completed an internal medicine residency at Washington University in St. Louis, Missouri, followed by a hematology and oncology fellowship at the University of South Florida Morsani College of Medicine, Moffitt Center. Dr. Chatzkel is an assistant member at the Moffitt Cancer Center, where his clinical interests center on providing personalized, evidence-based, and compassionate care to patients with my favorite word, genitourinary cancers. Would you say it once for me so I get it?
Genitourinary.
Wait, what's one word?
You could just call it GU.
How about GU cancers? I can just, that's the one word I can't do, including kidneys, prostate, bladder, penile, and testicular malignancies. His research interests focus on innovative clinical trials that provide access to cutting-edge therapies and expand treatment options for patients with GU cancers. Thank you, Dr. Chatzkel.
Thanks for
Appreciate
having
it.
me.
My pleasure.
So I know it's been a really long day for everyone, so I'm going to try really hard to do my talk in like 12 minutes, okay? No. Oh, well, okay. Well, I don't want to keep you all late. Okay, 13. Okay. So the goal of this talk is to tell folks, a little bit about, about what it's like for a patient or a family member to think about or potentially be involved in a clinical trial, a little bit about why we do them, and then I think, I hope I can try my best to get across some of the things that are put in place to try to make trials as safe and ethical as we reasonably can for patients. So, why do we do clinical trials? What are they? So in the simplest terms, it's really a study designed to evaluate new strategies for the prevention, diagnosis, or treatment of cancer in this case. And it basically is designed to test whether a new approach is better than the existing approach. And that can be in a couple different ways. It could be that the approach might provide a better response in different ways that we might measure it. Does it help people live longer? Does it help to shrink their tumors? Does it help to keep their disease from coming back, maybe after they have a kidney removal surgery? These trials are closely monitored and regulated, and most importantly, the participation is always voluntary. So, while I do want to briefly mention that I know Dr. Twaddle was here, palliative care, I think, in my personal opinion, is really incredibly beneficial for almost every patient that has a cancer diagnosis. Clinical trials are certainly an option that you can consider, or a family member can consider, as one option amongst many. Okay. All right. So again, why do trials exist? So, by carefully studying which treatments are the most effective, we can help to improve care for patients. So a lot of the care that we have for patients with kidney cancer today are really around because of clinical trials. So for example, first line, what we call doublet therapy, the combination of ipilimumab and nivolumab, or the combination of VEGF inhibitors and immunotherapy, really came out with some clinical trials that were presented when I was a fellow at Moffitt. For example, in addition, trials that helped to look at preventing a cancer from coming back after an nephrectomy, like the adjuvant immunotherapy trials. They came out and are still being looked at today. So lots of important advances are around because we have clinical trials. In addition, trials can offer access to promising therapies that might not otherwise be available. And I want to be really careful here because, and I always tell this to patients, we have this trial open at our center, or your cancer doctor, your family member's cancer doctor has a trial open at their center because they think that the intervention is promising. But we don't really know whether it's better in practice until we do the trial and really look at the results afterwards. So I always tell patients, we have this open because we think it's good science, but we don't know that it's going to personally benefit you as a patient. And so I think that's something that's important to know. So how do trials come up? It's not like I can just go in the morning before clinic and say, I'm going to do a trial today and then have it ready for a patient. Obviously, it's not like that. So it's sort of a long process. Investigators consider existing data and they ask a focus questions. So, for example, some of the people that invented or developed the seminal immunotherapies, they took a long time developing their hypotheses about how it might work, and then they started to study these interventions in people, first in very, very small numbers, and then progressively bigger trials trials and then eventually in combination with other things. And so, it's a pretty long process. A detailed protocol is developed. So essentially, before you open the trial or run the trial, you pretty much have what's called the protocol, which is like your sort of manual for how the trial is going to be run. And so pretty much almost every eventuality that can happen, it says exactly what you should do in that situation. And the reason, or one of the reasons why it's done that way, is because that way it gives a chance for some of the oversight, the bodies that oversee trials, to review it and make sure that it's ethical and makes scientific sense. So it's done for a reason, and it's really well thought out. And then lastly, the design has to be able to answer the question that's being asked. So for example, you may hear about different phases of trials, like there's a phase 1-2 trial or a phase 3 trial. And those different phases are designed to answer different questions. So if you look at some of the big meetings, we just had a big meeting at ESMO. There's the GU ASCO is coming up in January, and you see the big phase 3 trials. Those are really the trials that are asking that, in a lot of ways, the sort of the final question. There's an idea that's been found to be promising, safe in phase 1 trials, maybe preliminary promising in phase 2 trials, and the phase 3 trials are going to really evaluate the idea in enough patients to say, really, is this something that's ready to sort of roll out outside of the clinical trial setting? Okay, so trial ethics. So trials are only ethical when it's really uncertain which option was better. If we know which option is better, we wouldn't do a trial, we would just do that, right? So that's why we do trials. And then again, it's really important to know that if you or a family member are enrolled in a trial, it can be better, worse, or the same as the current standard of care, and that you might not personally benefit from it. So there's a lot of oversight, so I don't want to get too much in the weeds, and also I'm trying to be mindful of time. So I just want to briefly kind of make the point and hopefully demonstrate that there's a lot of oversight bodies that try to make sure that these trials are safe. So there's something called the Institutional Review Board, and they make sure that the trial, the risks in the trial is reasonable relative to the potential benefit and the knowledge to be gained. So really, it's looking at protection for patients and making sure that the trial is designed in an ethical way. And then there's a scientific review board that also asks questions like, for example, does the studied intervention make scientific sense? Does it make scientific merit? The things that this particular investigator wants to do we really think that there's good science behind it? And then the way the trial is written, is it going to be able to answer the question that's being asked? So if we, ask all these patients to give their very, very valuable time and, really commit to enrolling in this trial, at the end of this, are we going to be able to have enough information to say whether this intervention really benefited people? And so that's really, really important too. I want to talk very, very briefly about different trial designs that you might hear when you're talking with your doctor. So there's a single arm trial where basically everybody receives a specific intervention. You kind of, as soon as you sign up for the trial, you know what intervention you're going to get. And then there's a randomized trial where you don't know ahead of time. And so those can be used in different places. We'll talk very briefly. And then there can be open label or blinded as well. Open label is where basically you know what you're getting when you're on the trial, and blinded is when you don't know what intervention you're getting while you're on the trial. So for example, you might have heard of something called like a placebo, and that would be usually in a blinded setting. So when do we use randomization? Why do we use it? Essentially randomization is one of the best ways to remove bias. So, you have a much better chance of having a result that is going to be scientifically valid if you, assign patients to different arms by chance. And one thing to sort of emphasize that I think can sometimes be confusing is randomization is basically sort of like the flip of a coin. So it's not like when you're enrolling in a trial and the doctor is telling you about the two different arms, they're picking the arm that is best for you. Again, if we're designing the trial, we don't necessarily know which arm is best, and then it's going to be by random chance. So neither you as the patient, the family member, or the doctor necessarily gets to pick which arm you're on. Okay. And so this is just a diagram to show that it's just, again, by random chance that you can be assigned to the standard of care or a study intervention. So placebo, so this is something that can be a little bit tricky, and patients, I think, a lot of times have understandable reluctance about a trial that involves a placebo. And I want to just emphasize that the IRB or the Scientific Review Board would only let the investigators use a placebo if they felt like it was ethical. So I'll give you a very specific situation where a placebo might be used. So people that have had their kidney cancer removed, if they have certain pathology grade or stage that as it puts the cancer at high risk of recurrence, some of those patients we now know may benefit from an immunotherapy to help prevent the cancer from coming back. Now, before we knew that, it was considered ethical to randomize patients to either get a placebo, basically a saline infusion, or the immunotherapy drug. And now that we know that there is some benefit from giving people pembrolizumab after their kidney is removed in certain situations, it wouldn't be ethical to do that study anymore, right? So you could do a study where you do pembrolizumab plus something else versus pembrolizumab plus placebo, but it'd be really, really hard to do a study of just observation versus an intervention at this point in people with high-risk kidney cancer after nephrectomy. So again, the trial protocol, it clearly explains the purpose, procedures, risk benefits, and alternatives. This should say trial consent. So the trial consent is going to clearly explain the purposes, procedures, risk benefits, and alternatives. And it's really a time to consider and ask any questions. We as doctors, and certainly everyone that's involved in the clinical trial staff, we always want people to really think and consider it. It's not supposed to be a rush decision. In fact, in a lot of institutions, they have a rule where they won't let patients consent for a trial officially the same day that they hear about it, because we really, really want you guys to go home and think about it and make sure that it's right for you. And that voluntariness is just one of the absolute core principles of carrying out a trial ethically. And then again, very, very important, there's always the right to decline a trial. You can withdraw from a trial at any time. If you do so, your care is going to continue with standard of care interventions, okay? So that's really, really important to know. So another thing to note is that you may, if you've ever considered a trial, you may see a long list of eligibility criteria that's going to have what's called inclusion criteria and exclusion criteria. So inclusion criteria, they're going to look that your patient the patient will basically meet certain criteria. And the exclusion criteria, it's going to make sure that you essentially don't have anything on the exclusion criteria risk. And exclusion criteria list. So one thing I wanted to mention, I think is really, really important, is if you're considering a trial and you're not felt to be eligible based on those criteria, it only says something about the particulars of the trial. It doesn't say anything about you as a patient. It just means that trial is not a good fit for you, and you can either look for other trials, or you can even just potentially continue with standard of care therapy. So I think that's really, really important to mention. So what does it look like if you're involved in participating in a trial? So essentially, there's going to be a clinical trial coordinator that's going to help you walk through, the nuts and bolts of it. So they'll go over what the schedule looks like. They'll go over when your clinic appointments are going to be. They may talk to you about if there's additional testing that's needed. And they'll basically make sure that, remember we talked about that protocol, which is basically the manual for the trial. They're going to make sure that everything is really carried out according to that. And that's for patient safety, and also to make sure that at the end, when we've completed the trial, that we know that the results that we have are valid and are going to give us good information that we can use for future patients and to really help to move science forward. Another thing to note is that if you're on a trial, really all your symptoms and side effects are going to be tracked really, really closely, and serious side effects are tracked in real time. And there's actually another board called the Data Safety Monitoring Board. I know there's a lot of different organizations that I'm mentioning, but essentially they're going to monitor those side effects that people are having in real time. And if they see that there's a significant safety signal, they even have the power to stop the trial early if they feel like they need to do that, okay? All right. So a few practical considerations. So certainly, we're always really, really grateful when patients are generous enough to consider participating in a trial. It certainly can involve some additional commitments. So we may ask for potentially some additional visits. We may ask for some additional blood tests to be run. We may ask you to do some additional surveys, and sometimes there can potentially be a need for travel. Certainly, when I was at the University of Florida and similarly at Moffitt, people sometimes come a really long way to participate in trials, and we're really, really grateful that people can consider doing that. But it can sometimes involve that commitment of traveling a little bit. Now, one nice thing is that today, more and more practices, even out in the community, are making trials available. So there may be a need not to travel quite as far and still get involved in some really, really interesting trial opportunities, if that's something that's appealing. And then again, knowing the schedule beforehand. So this when you're thinking about a trial, when the doctor or the coordinator comes in and talks to you about what the trial might look like, knowing that schedule ahead of time can really help you decide whether it could be a good fit for you. So another few practical considerations. So usually standard of care items, so things that you would get anyway, would be covered by your insurance. This is going to be most of the time, and usually the study will pay for study-specific interventions. So for example, when we talked about that study for people after they might have had their kidney removed or a nephrectomy, when we didn't yet know that pembrolizumab helped those people, the pembrolizumab would have been a study intervention, and that would have been paid for by the study, okay? Versus, for example, CT scans, if patients were getting CT scans anyway for every 3 months while they were, after a nephrectomy, that might not have been covered by the study, that might have been billed to insurance. And certainly those questions are, again, things that can be answered up front. So another thing to mention is that trials are oftentimes available in lots of different settings. One really, really exciting area, development in not just kidney cancer, but in bladder cancer and lots of other cancers, is we're looking at more and more treatments to help potentially cure cancer at the time it's initially discovered or resected, and to keep it from coming back. So that's, for example, adjuvant pembrolizumab in kidney cancer, and then we have a lot of other interesting interventions we're looking at in bladder cancer, for example. So they're not always not only available as a last resort. In addition, some of the really, really exciting developments in kidney cancer, for example, the combination of ipilimumab and nivolumab, exit and pembrolizumab, those what we call doublet therapies that people get in the first line, they were also really developed through clinical trials and the generosity of patients really being involved in them to help show that those interventions benefited people. So they're not just a last resort, but again, they're always ultimately a patient's choice as well. So when I have people see me in my clinic, I may have a trial that I think is really, really interesting, and I might ask somebody if they're interested in potentially participating in a trial. And sometimes people say no, and that's completely okay. And then we just kind of carry on talking about standard care options, and I'm absolutely just as happy to take care of that person if they're not interested in a clinical trial. So it's completely fine either way, and patients should always feel that way. And then again, patients can decline participation or withdrawal at any time, and that's completely fine too. And no one's ever going to, fire you as a patient or anything crazy, like that. We're always really, really happy to take care of people, even if they decide that the trial's not right for them, either before enrolling it or during it, and they decide to withdraw from the trial. So I think we talked a little bit about this. So where to look for a trial? I think a really good first place is just with your treating oncologist, if that's applicable. They may have some options available, or they may know where you can look for exciting trial options, potentially at one of the universities, awesome university hospitals here in Chicago. But again, maybe just in the local oncology practice, there are more and more opportunities there as well. So. Okay, I think, what time is it? I don't want to keep people late. It's a little after 4. Why don't I just stop there, and I'd be really, really delighted to answer any questions that you guys have. Yeah.